incision on the abdomen, wherever is the incision, and because of the incision, you normally destroy a lot of tissues and a lot of cells. Once you open the patient's body, normally those cells and tissues release fluids, electrolytes, nutrients, and therefore they should have a replacement for all of those, especially after surgery, when those incisions should start healing, and therefore healing will not be possible unless there is adequate or optimum nutrition for a surgical patient. And therefore, to ensure optimum nutrition for a surgical patient, diet management may involve either enteral, okay, you have to insert a tube through the nose, through the gastrointestinal system. We need to, what is enteral? Intestine. Or parenteral, of course, nutrition. Parenteral could be IV fluids, it could be parenteral nutrition that normally is given. It's either peripheral or central, or we call it total parenteral nutrition, PPN, to ensure that the patient will receive the necessary nutrients, macro and micronutrients, to allow patient to heal the soonest possible time. And therefore, it is a must that nutrition should be watched out for closely, so that those damaged tissues from surgery would heal. Okay, this is a statistical report. It is said that a lot of people suffers from clinical signs of malnutrition, whether you're in the long-term care or you're in the hospital. For hospitalized clients who are undergoing surgery normally, and for most hospitalized clients, they could suffer from, there's something like 38.7 of elderly clients suffer from clinical signs of malnutrition. We will know later what are some of the clinical signs of malnutrition. And then 50.5% of elderly patients in rehab facilities also have clinical malnutrition signs. Effective nutrition therefore should reverse the malnutrition problem, to improve the prognosis so that he will live and he will not develop complication, and of course to speed up the recovery. That's the reason why nutrition is very central to the management of people who undergo surgery. Okay. Nutrition needs are greatly increased in patients undergoing surgery, that's obvious. Deficiency easily stop or develop because of the loss of electrolytes, fluids, and nutrients, depending on the nature of the surgery. If it is a very extensive surgery, you need to have a very good management of the nutritional intake that the patient should have. Nutrition is started before surgery should, therefore, this is the thing. You cannot undergo surgical procedure if your nutrition status is very poor, because healing and the probability of recovery or maybe developing complications is very high for people who have problems with malnutrition. But by the way, what is malnutrition? It's either you are undernourished or overnourished. When you are obese, you are also considered as malnourished, right? Therefore, obese people have very poor healing capacity. The fact is, even their wounds they open. We call it dehiscence and evisceration. Especially if you have abdominal surgery for obese people. Normally, because of poor healing, because of a lot of fats in there, therefore, normally the wound opens, it breaks. At times, the internal organ runs out of the body. Individual nutrition needs after surgery, of course, we always base on the needs of the patient and the nature of the surgical procedure. Okay, poor nutritional status are associated with, okay, these are the effects of poor nutrition. Okay, we normally associate them with impaired wound healing. The poorer is your nutritional status before surgery, the wound healing would be also impaired. Increased risk post-operative infection, because the less protein you have in your body because of protein breakdown, or we call it protein catabolism, normally it also lead to diminished immune response. It suppresses your capability to fight the infectious process when you have protein malnutrition, most specifically. Reduced quality of life, increased mortality rate because of complications. Of course, if you have had a surgery, we would not want you to have what you call complication. Therefore, that could lead to death or mortality. Impaired function of GI tract. There are a lot of what you call malabsorption deficiency disorder during the time that you had surgery, especially if the surgery has been a gastric surgery, which we will see later on. And of course, increased hospital stay and increased cost. Surgery is costly, and if you will extend more days because you develop complication simply because of nutritional deficiency, then it is really very costly. So these are some of the associated developments that could happen to a client when they suffer from, when they are having poor nutritional status. But that is just the background idea why we need to have a very good nutritional intake before and after surgery. So what happened? For example, you suffered from an emergency operation, maybe a vehicular accident, and your nutrition status is very, very poor. What will happen? You need to have your prognosis and your capacity to heal will be very poor. Therefore, on times like that, normally it will also affect your health and recovery as a whole. Pre-operative nutrition care. Nutrient research can be built up before elective surgery to fortify a patient. That's why, for example, if the patient is scheduled for surgery and it is not something very urgent, and they saw something is wrong with his nutritional status, we have to reinforce the patient by giving nutritional like hydration and nutrients so that he will be ready for surgery, especially after the healing process, meaning to recover after surgery. Protein deficiency are common after surgery. Take note of this particular macronutrient. Most common nutrient deficiency in surgical patients is protein. It's very, very important that you have enough protein. You will see later on what could be the complications if you don't have enough protein. Extra carbohydrates, sufficient calories are also required. Okay, why do you need to have sufficient calorie after surgery? Because you would like to spare the protein. Because sparing the protein will make healing faster, because protein is basically, the specialty of protein is for tissue regeneration and wound healing. Therefore, let the protein do its work and let carbohydrates do its work by providing energy for the patient in terms of calorie requirement. And therefore, you have to increase calorie for the patient who are post-operative. Extra carbohydrates maintain glycogen stores. This basically is your energy or fuel for the body. Vitamins and minerals deficiency should be corrected if there is, like potassium, sodium, phosphorus. Those are some of the minerals that have to be corrected. Vitamins, of course, vitamin A, C, D are very important also here. Water balance should be assessed. If the patient is dehydrated, therefore he should be properly given fluids. So, this is basically on the pre-operative nutrition care. We have to assess all of these different items so that the patient will be prepared for surgery and recovery after surgery. Okay. Patients are typically directed not to take anything by mouth 8 hours prior to surgery. And before GI surgery, a non-residue diet may be prescribed. So, since a gastric surgery involves emptying totally the gastric content, then we have normally enema and a non-residue diet so that you will not produce anything in the bowel. And non-residue elemental formula provide complete diet in liquid form. What did we say about elemental feeding? When you say elemental formula,
It's unabsorbable.
yeah, they are already pre-made, prepared, food in its simplest form. And therefore, they are just going to be absorbed by the body to be utilized. If it is carbohydrates, protein, fats, they will have just to do its own function for the body. So those are non-residue elemental formula that can be given pre-operatively to prepare the patient so that his capacity will be boosted or increased. Emergency surgery, this is what I'm trying to say before. No time for building up ideal nutrient reserves. There's no way. The problem is there. You need to be operated now. You cannot postpone it. So that's why there's a good reason for maintaining good nutrition status at all times. So that if there is an emergency, you have a reserve, you have a way of defending yourself, and your capacity for healing and recovery to just be as normal as possible when your nutritional status is just right. Because operatively, this is now what we basically are going to be tackling now. Okay. Post-operative nutrient losses are great, but food intake is diminished. We know that. As we said, by the time you open the patient's body, you lose blood, fluids, electrolytes, you damage tissue, and therefore you lose a lot. But your intake is diminished because your NPO, nothing by mouth, you only have their IV fluids. Protein losses occur during surgery from tissue breakdown and blood loss. Because a lot of protein are in your blood, plasma, right? Including albumin. That's a very important protein. What are some of the other protein in your blood? And of course, any cell that breaks down because of the surgical procedure leads to what you call catabolism, the destruction of the cell. Normally, you lose the protein inside the cell. Okay. So bleeding or blood loss, you lose a lot of protein. That's why we said before from the beginning that protein is one of the most common macronutrient that is deficient in a client who undergoes surgical procedure. Catabolism usually occurs after surgery, tissue breakdown, and loss exceed tissue build up. Okay. What is the first? How do you know that you are losing a lot of protein? What is your measure? What is in protein that is not in fat? In carbohydrates. Nitrogen. Therefore, what will happen to your nitrogen balance? Will it be positive or negative? You will have negative nitrogen balance. Okay, meaning you're destroying more protein, but you're not taking in more protein. Therefore, the effect is negative nitrogen balance. Okay. So for post-operative recovery period, why do we need to have a lot of protein? This is another question. Can you defend your answer? Why do you need protein after surgery? Aside from wound healing, that is already given. What is the other role of protein? Aside from healing and recovery. If you don't have that, what happens to the fluids? What do you want to control for protein? You need to have a lot of protein because you will be able to control this particular sign.
Bleeding?
Not bleeding. Bleeding is basically, you need blood clotting factors to control bleeding. Somehow protein will contribute, but basically, what was that particular principle? It's basically connected to osmotic pressure.
Fluid.
Fluid balance.
Yeah, fluid.
So if you have lack of protein, where will the fluid go?
Cell.
Therefore,
Edema.
so what do you prevent? Edema. Okay. Because what is the mechanism? What is the characteristic of albumin as a solute? Will it drive fluid or will it attract fluid?
Attract.
It will attract fluid by virtue of osmotic pressure. Therefore, if you retain the fluid within that compartment, for example, since albumin are basically found in most of the plasma of the blood, if you remove the albumin there, outside of the blood vessel, normally, there are more solute then. Because you remove the solute, you remove the albumin, no more. Therefore, by virtue of osmotic pressure, all the fluid inside the blood vessel will escape out and it will cause what? Edema. Therefore, the reason why we have to have a lot of protein after surgery is to prevent edema. Because lack of it will cause shifting of fluid from one compartment to the other. From intravascular, it will become interstitial fluid, right? So we prevent that to happen. And did you notice, for example, after surgery, that there is the incision site normally is a little bit inflamed. There is a little bit edematous. Why is that? Because the protein inside the cell escaped out, and therefore the fluid also escaped, and it became manifested on the swollen area of the damaged tissues, which are basically composed of cells, catabolism. So take note of controlling edema. Okay. So need for increased protein are here. Building tissue and wound healing. Number 2, controlling edema. It's already here. Controlling shock by maintaining blood volume. That's very true. Because if you allow the water to escape out of the blood vessel, what happened to your blood pressure? It will become low. If your blood pressure becomes 80 over 40, 60 over 20, you are going to have hypovolemic shock. Because there's no adequate blood pressure that could maintain a good cardiac output, that the heart could be pumping. And therefore, it's very important to control shock by maintaining good amount of protein and blood volume within your blood vessels.
What about if you have a high blood pressure during your surgery?
We have to lower that.
So what's the cause of that?
Oh, of course, there could be a lot of high blood pressure because of high blood. Maybe there is something wrong with the blood vessels. The blood vessels are not compliant in type. Maybe there's a narrowing of the blood vessel, or there might be other organ that is involved, like the kidney, or maybe you have fluid congestion, or you are really hypertensive as a person genetically. There could be a lot of reasons why to do it. Or you have maybe you have a lot of aldosterone that has been released in the body, that you retain the sodium that causes the hypertension. Or maybe you're just simply too nervous. that causes your high blood pressure. That's why you have to pacify the patient before surgery to relax him, to relax the muscle because that increases the tension and the distress normally increases BP. Okay. Healing bone protein is of course essential. Resisting infection, protein tissues are major components of the immune system. Once you lower your protein, your immune capability will also be diminished, your ability to fight infection. Because why? Because antibodies are made up of protein. So you know that? And therefore, if you lose those protein that makes up your antibody, what will happen to your immune system? You cannot fight infection with a lack of antibodies that are basically made up of protein. Transporting lipid fat is an important component of tissue structure. So basically, these are some of the reasons why you need to increase protein after surgery. So these three are very important: maintaining wound healing, controlling edema, and controlling shock and maintaining blood volume. Once you have that in order, then healing would be and recovery would be faster for the patient. Okay. What about water? Of course, water is something very important to prevent dehydration. All chemical reactions that happen inside the body are basically happening because of water. Of course, water is a very good universal solvent for all the things that comes into the body. So we need that all the time. Hydration normally improves healing. Okay. And elimination of toxic products. Okay. Large water loss possible from various routes. Meaning you can lose a lot of fluid, maybe from nausea, from vomiting, from perspiration, from blood loss, excessive sweating. Those are some of the areas where you can lose a lot of fluid. And IV fluid could be the option, which is a therapy. Normally after surgery, you live on IV, right? The first 24 hours, normally, you just have IV there, IV fluids with electrolytes. Then, the following day, you start to eat what? Clear liquid diet, then it is shifted to full liquid diet, then soft diet as tolerated, then until you become regular, depending on the nature of the surgery and the location. Of course, if it's a GI surgery, it will take more time to heal that particular operative site before you can probably assume or resume oral intake of food. So oral fluids as soon as possible is given. So when do you give fluid for a post-operative patient? Regardless of whether it's minor or major, especially for major surgery. We normally give fluid when the patient's gag reflex returns, meaning he is able to swallow them. Because of the effect of anesthetic agent, we normally have to test whether the patient is already making a gag. How do you make a gag? You try to put on the last part toward the next, at the end of your tongue, the tongue blade, and if the patient make a swallowing reflex, then that's a gag reflex if he swallows. Energy. Okay. As we said, what is the source of energy after surgery? It should be from carbohydrates, right? The fuel of the body, and this is basically what we have to provide sufficient non-protein calorie for energy, to spare protein for tissue building. We have the for male, basic metabolic rate is equal to 10 times weight in kilogram plus 6.2. Never mind this one. You are not dietitian to compute. Okay? it is leave that to the dietitian. What we should know only is what are the food that the patient should be eating after surgery, more or less the amount of energy needed. If it is 2 kilogram, 2 gram per kilogram, something like that. That is the most essential thing that we should know only. Nothing much on the computation. Of course, there are computations in the nursing board, but it is usually based on the pharmacological question, not on nutritional questions. So, treat it that way. So, these are some of the vitamins we also need. C, so that the tissue would stick together, because connective tissue, it will improve the connection of the meaning the healing and the connection of tissue from one another is strengthened by vitamin C. B complex is to metabolize protein and energy, meaning they hasten chemical reaction, just like acting as coenzymes. And vitamin K, of course, is to promote blood clotting. So those are some of the vitamins that are needed after surgery. If you have problem with blood clotting, if you have the tendency for blood not to clot, then you need vitamin K, and you should know where your vitamin K should be taken from. Deep green vegetables are rich in vitamin K. Minerals, potassium, phosphorus, sodium, chloride, iron, and zinc. Okay. Another question. What are the important minerals lost from tissue catabolism? What is tissue catabolism? Yeah, when your tissue or cells are destroyed, are broken, then you release certain minerals that are very important. And among these different minerals, potassium and phosphorus are the minerals lost from tissue catabolism. They are the important minerals that are lost from catabolism of tissues or cells. Okay, that's the only thing you have to mention about there. So take that particular idea. General management of the diet. Okay, routine IV fluid supply for hydration and electrolyte, but not energy and nutrients. So the reason why we give IV fluids is just for fluids, meaning for hydration, because cells should be adequately nourished in terms of fluid, of water, and of course electrolyte. What is the role of electrolytes? Like sodium and potassium. Once you put electrolyte in water, what happens? You produce very, what do you call that? Very small electrical waves. Okay? And therefore, that allows muscle to contract. So, basically, that is very important metabolism in movement of fluids, movement of nutrients, oxygen, in a particular medium. Therefore, you need to have electrolytes. Methods of feeding: oral, enteral, parenteral. Okay, when you say oral, the patient should be swallowing by this time, right? And he needs to chew the food. When you say general diet or regular diet, would you include anything in the diet like things that are not chewable? Okay, what I'm trying to say is, when you say regular diet, all the food that you have to include there are the food that can be chewed. Will you include puree?
No.
In that particular diet? No, because they are not chewable. You just it's basically almost liquid. You say puree. It's not even mechanical soft. The mechanical soft diet is they are finely chopped, but even that you can chew it. Therefore, that could be part of a regular diet. Only that the texture is modified so that it can be softer. So normally we progress from clear liquid What would you include in a full liquid diet? Every liquid, including what? Ice cream and chocolate. Anything that can be dissolved, like that dissolves, like ice cream, chocolate, they can be dissolved. They are considered as part of the full liquid diet. Okay, full liquid. So take note of full liquid. You may include chocolate, ice cream. But for clear liquid, you don't normally put this one. Anything that has fats, normally you don't put that in a clear liquid diet. Even you can give the part of the clear liquid diet. You can have the root, but you have to screen because normally there are some solid thing in there. Only the water part can be given as part of the liquid diet. Methods of feeding. You have enteral nourishment through regular GI route, either by regular oral feeding or by tube feedings. So when you say enteral, normally is through the GI route. Okay. If you're going to give enteral feeding, would you rather give because there are people who would blenderize different kinds of food, like blenderized vegetable, blenderized fruits. Which is preferable after surgery? Would you rather go for the commercial enteral feeding or the blenderized one that you prepare, that you buy in the market?
Commercial.
Why? Yeah, you're correct. It should be the commercial one because normally you're not assured whether these things that you have blenderized are free from bacteria. So they are raw, they are fresh. But we have to prevent infection for a patient like this who are post-operative. So it is more safe to have the commercial enteral feedings because of the risk of bacterial growth in infection coming from this raw food that we normally blenderize, whether they are vegetable or fruits. Of course, in terms of the nutrients, they have a lot of nutrients. But then the risk is we cannot just reach the patient's recovery if he suffers from infection. Okay, so I think parenteral nourishment through small peripheral veins or large central vein. By the way, there are two ways by which we can give what you call parenteral nutrition, meaning it comes into the vein. Wow. For the peripheral nutrition, we normally insert it on the cephalic vein in here. Okay, cephalic vein. And they are elemental feeding normally. They are prepared in its simplest form, ready to be absorbed. On the other hand, we have a large central vein. Normally, it's on your, what is the vein here? It's going to the directly into the superior vein of what is that vein? Anyway, let me see. I think it's in the figure.
It's blue.
Oh, this is the cephalic vein, basically for your peripheral nutrition, and this is your subclavian vein. This is another way for total parenteral nutrition. We have the central, we call it the central nutrition therapy. So from this particular subclavian vein, it goes all the way to your heart right away. So it's just right here. You prick in there inside, and then the tube is connected, and directly from the pump machine you have the elemental feeding going on. So that's the two ways of giving parenteral nutrition to a client. peripheral and parenteral. I don't know if you have seen one before. Okay. Of course, the best way is to have the patient to take it orally. Okay. Allows more needed nutrients to be added when it is taken orally. It stimulates normal action of the GI when you make it oral. Early feeding associated with reduced complications. So when you give feeding, you gradually initiate the client from clear liquid to full liquid to soft, something like that, and patient is responding appropriately, then there is reduced complication as documented. Progress from clear to soft to regular. Assisted oral feeding, never mind that. Methods of feeding, this is your, of course, your nasogastric tube feeding. Okay, all the way going to the jejunal. Which is your jejunum? Is the second part of your small intestine. It could be jejunostomy, meaning there is a direct bore or hole in your stomach that directly goes into the jejunum. We call it jejunostomy, J-tube. We call it normally J-tube or jejunostomy tube. Of course, gastrotomy tube is, where do you put that? Directly into the stomach. Okay, with a peg placement. Meaning percutaneous, endoscopic, gastrostomy, peg replacement or peg placement. Call it. This is what you call esophagogastrostomy. So meaning from the esophagus, from the mouth, going to the esophagus, then to the stomach. Then it could also be jejunostomy, which is in the jejunum. That's why we have here percutaneous endoscopic jejunostomy or the peg. Okay. Anyway, where is that? Where is jejunostomy indicated? Okay, let me just continue that later because when we go for the gastrectomy, then there are indications what kind of tube feeding will be indicated for each one. Anyway, this is another question. Advancing carbohydrate load in TPN too quickly can result in hyperglycemia. We were talking before about the peripheral and central nutrition therapy. Okay, the TPN, total parenteral nutrition, parenteral feeding. By the way, just for our own knowledge, when you say peripheral parenteral nutrition, normally it's for short-term course of feeding. Like if you're going to give the patient only for 5 to 7 days, so you can use the peripheral vein here, the cephalic vein. But if it's going to be for a longer period of time, then let's say months, then you need to have the TPN. Okay. For large nutrients needs or longer periods, then you need to have it on the central line, not on the peripheral line. It must be discussed with the patient because you are connecting it directly to the patient. It's a very invasive procedure. So patient should have informed consent about what is it all about and why does he have to need to have those kind of placements. So as we said, this is your total parenteral nutrition. One of the complications of administration of this one is when you're giving it too much for the patient, normally the patient suffers from what kind of complication? Hyperglycemia. So Advancing carbohydrate load in total parenteral nutrition too quickly can result in hyperglycemia. For example, if the patient's TPN is regulated at 40 ml per hour, or 40, how many drops per minute, if you give more than that, because you're overloading the patient with carbohydrates, then it could result in hyperglycemia. Therefore, one of the nursing responsibility when we are giving TPN is to monitor for blood sugar, because that is one important complication. So we never have to, we don't have to overload the patient with the TPN. You don't have to make an advance, just probably regulate it so that to prevent hyperglycemia. Okay. So this is your, so imagine from here, if this is your, what is this vein here? Cephalic vein that goes all the way here, and this is your subclavian here. This is another. There are two. This is the peripheral. This is the central line here, subclavian vein. Did you see somebody like that with tubes here? And that is where normally we put the connecting tube from the TPN. It's very direct, going right away to the heart. Especially after surgery. Okay. So basically we are just going to discuss it in passing. When you have mouth, throat, and neck surgery, we modify also the nutritional need because you cannot chew and swallow. Therefore, oral feedings ensure adequate nutrition. Mechanical diet may be optimal. Enteral feeding required for radical neck or facial surgery. So enteral feeding, meaning you have to do it by the gastric throat, either jejunostomy or what is the other one? Gastrostomy. Problems may develop immediately after surgery or after, okay. Because the stomach is the first major food reservoir in the GI, the stomach surgery poses special problems in maintaining adequate nutrition. We know that because that is normally where food passes. If it's a GI surgery, therefore it could complicate nutritional status of the patient. Now we move on to gastrectomy. What do we have to monitor in a patient with gastrectomy? What is gastrectomy? You remove something in the stomach, either partial or some part of the stomach that probably is affected. Like maybe you had the massive ulceration there that you have to do what you call gastrectomy, partially removing part of the stomach. Okay. So weight loss is common. Patient may be fed by jejunostomy. So take note of this. Immediately after gastrectomy, feeding is met by jejunostomy tube. Of course, we normally have a TPN via jejunostomy tube. So we give the elemental feeding through the jejunostomy tube. The reason for that is we would like to allow the stomach to heal. We are not going to use the stomach for the meantime. Therefore, the elemental feeding will directly go into the jejunostomy. And the jejunum of the patient, which is basically what? A portion lower than the duodenum. Okay, so that's one indication of meaning to be able to meet the nutritional requirement after gastrectomy. Then jejunostomy is an option in terms of enhancing nutrition for this kind of client. Now, there could be a problem that may happen when the patient had gastrectomy. And what could that be? This is the thing that we have to monitor, dumping syndrome. When you dump something into the intestines so fast, too much too soon, what could happen? These are some of the symptoms of dumping syndrome. The patient may feel cramping in the intestine, feeling of sensation of fullness, rapid pulse, waves of weakness, cold sweat, dizziness, nausea, vomiting, and diarrhea. And those are the signs of dumping syndrome. Why do patients suffer from dumping syndrome? Again, anybody would like to explain using the principle of osmotic pressure again? What happened? When you dump something in there, what happened to the fluids? Okay. Even if you are giving elemental feeding, and it looks like fluid in there, they are composed of solutes, right? Carbohydrates, protein, fats are there. All the elements of macronutrients, including the micronutrients, minerals, and vitamins probably are also there. When you dump it so soon, what happened to the fluids in the surrounding area? Where will the fluid go? It will be attracted where? Into the intestine. It will increase fluid inside the intestine because they are solute. The elemental feeding that you are giving are solutes in themselves, although they appear like fluid, but still there are a lot of solutes in there. When you dump the solute there, because there is increased osmotic pressure inside the intestine, all the other fluids outside the intestine will be drawn into the intestine. That will cause cramping, diarrhea, nausea, vomiting, rapid pulse, cramp, and all those different symptoms. So basically that's what happened. What will happen to your blood pressure?
Go up.
Because you have withdrawn all the fluids, maybe including the fluids from the blood vessels in the surrounding environment. It will cause hypotension also, because the fluids are in the intestine. They are not in the blood vessels. Hypo. Normally, in the first 30 to 60 minutes after meals. This is assuming that the patient is already eating after after a gastric surgery. Meaning, one of the nursing care for people with a dumping syndrome or gastric surgery to prevent dumping syndrome is to give the food in small amounts so that you will not dump so fast. Because what happened to the area of your stomach? The area of your stomach becomes smaller, and therefore the tendency of that is to dump right away. If you have more food that is coming in, to dump it on the intestine. That causes the dumping syndrome thing. So, what is the explanation behind the science? Meaning, this is you have to think. No, the physiologic symptom of dumping syndrome result from. Meaning, this is the reason why the symptoms exist. Result from water being drawn from the blood into the intestine and decreasing the blood volume. So you see the effect. It decreases your blood volume, therefore it decreases your BP also. Because the fluid in the blood are withdrawn into the intestine. That's the effect of the physiology. That is what dumping syndrome is. That lead to the physiologic symptoms, such as cramping, rapid pulse, waves of weakness and dizziness. Okay, just try to memorize also the signs and symptoms, but you should know the reason why the symptoms appear. And as I've said, water being drawn from the blood into the intestine and decreasing blood volume is the reason why you have those physiologic symptoms or what you call dumping syndrome. So, result in patient eating less. So if you feel have that if you have diarrhea, nausea, and cramping, you don't feel comfortable, and therefore you eat less. So the more you become malnourished then. So that's an important care measure that we should know also for people with gastric surgery. So bariatric surgery is what? Typically deficient in several micronutrients, struggles from clear. Okay, what is bariatric again? You try to make the lumen become smaller so that little food will come inside. Bariatric. Especially for obese people, they have to reduce the amount of food entering into the stomach so that they will not have so much nutrient in there. But it can also lead to dumping syndrome. For gallbladder, since the problem here is we normally have cholecystectomy, right? And surgery is mainly okay. Some moderation in dietary fat is usually indicated, okay, depending on individual tolerances. So what we're trying to say here is the fat, the dietary intake of fat is normally diminished when you have cholecystectomy or gallbladder removal. Okay, because we know that the gallbladder is the one that concentrates the bile and restore it, and it is being poured into the duodenum once there is fat that is in there. So therefore, since the gallbladder is not functional, then we have to reduce the amount of fat intake. Intestinal surgery. Okay. What are some of the intestinal surgery that you know? We have, for example, ileostomy, colostomy. Are you familiar with this terminology? Ileostomy is opening into the ileum, and maybe there is a lesion or what you call a cyst or a cancerous growth, neoplasm in the bowel, and therefore a colostomy will have to be done, or an ileostomy. So a stoma may be created for elimination of fecal waste, but the problem here is when you have ileostomy, because an ileostomy is what? When you say ileostomy, it's the end of the small intestine towards the large intestine, right? Then you say valve. So once you open the stoma there, the fluid or the fecal material that will be coming out of the stoma are what? Generally fluid. Because normally the waste product of digestion from the food that you eat normally are formed where? It begins to form from the transverse colon going all the way to the descending colon until it forms stool. So therefore, if it is on the level of the ileum here, what is the characteristic of the fecal material? It is basically liquid, and take note of liquid. Ileostomy. The drainage is generally liquid in an ileostomy. Meaning there probably are still some nutrients that has to be absorbed in there. Of course, for colostomy, normally, the colostomy is on the left because it's not on the descending colon here. And normally you have what? Either you have a soft or formed fecal material when you have colostomy that we normally clean every day. Have you seen one? Yes. Patient with colostomy? Okay. So, for ileostomy, normally the stoma is here. Okay. Is it the right or the left? Oh, this is the ascending colon, the transverse colon, and this is the descending colon. But this is the ileum, the terminal end of the small intestine. And therefore, this is where the fluid is coming out here. Of course, it's something very irritating to the skin. That's why we normally we normally avoid having contact of those fluid into the skin because they are irritant to the skin. Okay. For rectal surgery, clear liquid or non-residue diet may be indicated after surgery to reduce painful elimination and allow healing. And normally, he returns the diet as soon as possible at time. Right? It's not much. One of the important thing about the next topic is how do we care for patients who suffered from burn injury. We're taking care of post-surgical patient, but burns is one of the patient here that will have to be included in here. Of course, when there is a burn injury, just like in surgery, especially if the burn is 2nd degree to 3rd degree burn, you also have a lot of damaged tissues and cells. Once you damage the tissues and cells, electrolytes, fluid, plasma escapes out of the body. Have you seen a burn patient? Normally, he is edematous on the area of the burn. Therefore, all the fluid shifted out. And therefore, that's a very immediate something that you need to resuscitate the patient in terms of fluid requirement. Because if there is a very extensive burn and he has a lot of 2nd degree to 3rd degree burn, the patient might suffer from hypovolemic shock because all the fluid has escaped out and the patient is edematous all over. That is something very serious then. That is why we normally have a complication for that. If the patient suffered from at least 30% of the body burn, you would need something like 7 to 8 liters of fluid in 24 hours so that you will hydrate the patient, depending on his total body surface area, because for the computation is based on that. But you will take that with your pharmacology anyway, how to compute for fluid needed for burn injury. Okay, so plan of influence by age. Of course, the younger you are, the more you lose fluid from burn. And also as old people. Health condition, if you have a health condition, or the severity of the burn, if it is a 3rd degree burn, meaning it has go deeper into your subcutaneous area, then you need more water because of the damage. Meaning, the more damaged tissue there are, the more catabolic process there are, the more escape of fluid and electrolyte, the more you lose water, the more you have to reinforce and adjust nutritional status for a burn patient. And the plan is constantly adjusted because of that. Every day there is supposed to be a particular focus. Normally, the first 24 to 48 hours is the fluid and electrolyte that will have to be restored. On the 2nd or 3rd day, then it is the albumin, the protein that will have to be stored until the healing process. Meaning it's a gradual process of depending on what kind of things is happening or need that is determined. So critical attention is paid to amino acids, which is basically what? Protein. Okay. Okay, this is your degree of burn. Superficial basically is on the superficial part of the skin. Partial thickness, we call them. The second degree burn is when you have blisters that has water inside. The deep partial thickness is basically coming in this particular area of the dermis, okay, where you have the blood vessels, the hair follicles, and the sebaceous glands. The full thickness burn is when it has reached beyond the subcutaneous area with the fatty tissue, including the muscles. That's the deep full thickness burn. But we consider it's also full thickness when it has reached the subcutaneous area, from this area all the way going down to the bone. So from the fatty tissue all the way to the bone, we call that full thickness burn injury. Of course, as we said, the deeper is the burn injury, the more nutrition or fluid you need for the resuscitation of the patient. Okay, this is the first stage of the burn injury. As we said, there is massive edema at the burn site, and because of that, you lose a lot of heat, water, electrolytes, and protein. And therefore, our immediate response would be giving IV therapy with salt solution or lactated drenchers. Okay. In that regard, what would be the initial treatment for burns? IV electrolyte solution. Electrolyte. When you say IV electrolyte solution, the salt is a solution to replace water in electrolyte to prevent shock. Because if you don't have electrolyte, fluid will continually drain out of the body, and therefore you will suffer from shock. That's why there should be electrolyte to conduct wave of motion so that the cells will function again. So basically, to replace water, and the salt is basically to replace water, because as we said, salt attracts water, is that right? And therefore you retain the water. What about electrolyte? It prevents shock. So retain the water or replace the water through the salt, and prevent shock through the electrolyte. That's why we call it electrolyte solution. When you say electrolyte solution, it's composed of water and electrolytes. Like normal saline solution, it has saline and it has water. Now, what kind of solution are you gonna give initially? As a matter of protocol, the IV solution to prevent hypovolemia or hypovolemic shock immediately after a burn injury is what? Lactated drenchers. Take note of LR. That is your IV solution that is given immediately after the burn injury to prevent hypovolemia or hypovolemic shock. Because LR is what? It's a salt solution with 6% heta starch solution. It is a salt solution. It is composed. LR is basically composed of salt solution and 6% heta starch. What is heta starch? That is the one that thickens the blood, so that if you thicken your blood, it will increase your blood volume, and therefore it will increase your BP. Therefore, you prevent hypovolemic shock. Hypovolemic shock is characteristically with very low BP, right? Then we have to increase the BP by giving fluids and electrolyte. So LR is what you call the IV fluid of choice for treating burn, especially on the first 24 hours. After 12 hours, then you can give albumin solution or plasma. Plasma. MNT. What is MNT? Medical nutrition therapy are not a priority at this time. Not food, but fluids and electrolytes. Especially in the first 24 hours. So this is now the second phase, the acute flow phase, sudden diuresis. So as you give the patient hydration and fluid resuscitation therapy, you would know that the patient would respond by having diuresis. He would urinate. Meaning if the kidney is functioning well, patient will urinate a lot as an indication of initial success to the fluid therapy. Constant attention to fluid intake and output should be monitored. Around the end of the first week, bowel function returns and regulars. Now, that's the only time you have to give medical nutrition therapy towards the maybe the fourth, fifth week of fifth, 6 days. Because on the first few days, normally is the fluid electrolyte that will have to come into play as the priority issues for the treatment of a burn patient. Okay. So what is constituted now in the medical nutrition therapy? MNT, high protein. That is because you have lost a lot of protein from the tissue catabolism. High energy intake, of course, that is your carbohydrates. Caloric is based on total body surface area. Basically, when you say high protein, that is equivalent to 2 grams per kilogram per day. So if you are 100 kilogram, that could be how many grams of protein? 200 grams. That's a lot. When you need only something like 50 on a normal daily basis, if you are not having this burning. For high protein, high energy, you need 25 to 30 kcal per kilogram per day in terms of high energy intake. And how much is that? 25, if you are 100 kilogram person, you need how many? Is it 2,500? Yes, that's a lot of calorie from carbohydrates. Just to give you that medical nutrition therapy. And liberal portion of calorie from carbohydrates, avoid overfeeding the patient. High vitamin and minerals intake also are needed at this time. So that's how we take into consideration. Then follow dietary management, careful intake and output, because we would like to consider also whether the patient is retaining to have a fluid balance, or he might be urinating a lot also. So we have to make sure that the fluid should approximate the output, intake and output. Oral feedings are prepared so that the GI function would immediately recover. As we said, healing is faster when you take the oral food. Enteral and parenteral route may be used if oral intake is deficient. Follow-up is reconstruction. Normally, after some weeks, we have this skin grafting and reconstructive surgery for final rehabilitation after that, to rebuild the tissue and the spirit of the patient, because normally if you have burn, what happened? Your body image and self-esteem is also affected. If you saw yourself, oh my God, I have no more nose, what happened to me? That therefore, you have to rebuild the will and the spirit that life has to go on and he should move on. Good for him, he did not die. He is still alive. So that's your did we omit something here? Any questions so far?
No?
I think it's a patient of very important points.
Yep.
Okay, let's move on to the next chapter so that we will finish on time. If we finish before 11, before 12, then we could go for last early on. Okay, goodbye. Last chapter. Okay, you must be interested in this because it's all about HIV and cancer patients.
Okay, I'll take it.
Do you need a bladder break?
Yes.
Okay, go.
Wait, I thought you were playing now.
Hey, I guess the going to 85?
I guess we're still going into that, right? Oh, it's birthday?
No, it's not birthday.
I think bring this one because there are 3
Okay, do I try with all these? Just
Yeah, just
okay.
scan.
Okay, thank you. Oh, very tired.
What is that?
And anything in the environment, normally there are environmental factors that cause cancer. The strength, therefore, it is in this particular life when your body immune system becomes low that we suffer from malnutrition, or probably it's vice versa. Because of malnutrition, normally your immune system is low. And because your immune system is low, you are vulnerable to develop cancer. That's what I'm trying to say. The strength of the body's immune system relates to its overall nutritional status. This is a very important statement. For as long as you maintain a good nutritional status, you will also maintain a good immune system, and therefore the chance of cancer is far away because of that. And unless you have genetic factors in you, it runs in your family. Whether you have a very good nutritional status, but all the more it is aggravated by when your immune system is low. That's what we're trying to say. Nature of cancer. So, cancer designates a malignant tumor. Of course, it starts with the mutation of a particular cell. It normally starts into a small cyst, or we call it neoplasm or growth. Then, after some time, it becomes big and metastasizes and move from the original site, and therefore that becomes malignant and metastatic until the patient can no longer control the rapid proliferation of the cell, the cancer cell, that causes death. So, cancer cell or the early process of cell division. Of course, normally if you don't have cancer, our cell divides by mitosis. Normally, cancer cell basically is now a new, meaning it starts from a normal cell, and because there is probably a disturbance in the chemical and genetic, activity, and so there is what you call a mutation of the DNA that resulted to a new cell. We call the new a neoplasm or a cancer cell that will lead to tumor. In the beginning, you can just find it from the primary site. If it is on the abdomen, it is just there. If it is on the foot, normally that's on the foot. If it is on the breast, it has the meaning of primary site, or the cancer is in situ. S-I-T-U. Not me too. When you say cancer in situ, it is just localized area, that localized area. Stage of tumor size and metastasis. Normally, the tumor can be categorized as small, large, medium, large. There is a grading system. We call it T and N. I don't know if you have heard. Meaning when you say T, is the tumor. And the score is 1, 2, 3, 4. 4 is the biggest. M is the what you call the lymph node. Meaning, if it is in what lymph node, it is also is for us 1, 2, 3, 4. N is for metastasis. Meaning if it is distant, if it is local, if there's no middle, it is also scored as 1, 2, 3, 4. For example, how many lymph nodes are involved in terms of disease spread, there's also a scoring like that. But you will do that anyway when you have your oncology nursing subject. Okay. So grade level of aggressiveness, how far it has gone and spread into the body. Because there are cancer within a matter of few months, it is all widespread already. You were very healthy 2 months ago, but after 2 months, the cancer is already widespread. It's something like that. Very aggressive. Dietary factors in the development of cancer. Of course, there were researches that were conducted, but up until now, they said that there is no hard evidence that will singly say that this food is the cause of this cancer. Meaning, of course, there is a tendency, meaning an association. What we can only say is, for example, if you're taking a lot of saturated fats, it is normally associated only to colon cancer, right? Thus, you're taking dietary fat, saturated fat. But there is no study that would prove by evidence that the fat that you are taking, saturated, is the direct cause of colon cancer. There might be some other factors. Maybe the fat, the saturated fat, is just the reinforcing thing. That is why it's normally associated with colon cancer. But it is not the direct cause of the colon cancer. And that's why there is no hard evidence on carcinogenic food. There are conflicting results. There is no established evidence as to this up to this day. Micronutrient imbalance linked to DNA damage and cancer. Meaning, because of the imbalance of micronutrients, there is also a predisposition that will lead to the changing of the DNA structure that lead to the mutation of a new cell, which we call now the cancer cell. Okay, so that's also one way of explaining the cause or the association of the dietary factor in cancer development. There is an association, but there's no hard evidence. Bottom line. Body defense against the cancer. There are two types, of course. Are you done with immune system? Okay. I also taught anatomy and physiology the whole week this week. We are finishing on Thursday for our final exam. I have 30 students in my class. 70% are passing. That's a difficult subject. Okay, anyway, these are the lymphocytes. Meaning, the lymphocytes are the T and the B lymphocytes, which is responsible for defending the body against any foreign invaders. Basically, the B lymphocytes is for the production of antibodies. The reason why you have antibodies in your system is because of the B lymphocyte. The T lymphocyte is the one that directly attack any foreign invader, whether it's virus, bacteria, or a cancer cell. Okay, the T lymphocyte produced by your what is a lymphocyte? It is basically a white blood cell. White blood cell is divided into what? Granulocytes, agranulocytes. Under agranulocytes, we have lymphocytes, monocytes, right? And the lymphocyte is B and T. Okay, you know that in anatomy. So now, these T lymphocytes are the one responsible for directly attacking any foreign invasion. And we consider cancer cell as foreign invasion because it doesn't normally belong to the body. Meaning the T cell is able to recognize which does not belong to the cell. It recognizes which are the normal cell, which are the abnormal cell. And once the T cell is able to detect that that's something that does not belong to the cell, they will launch an attack against that particular cell, therefore trying to suppress the development of cancer. Understand that mechanism? Okay. And that could happen either by phagocytosis, endocytosis, all those different mechanisms of trying to neutralize. Of course, the B lymphocyte will be activated also. We call it the complement system will be activated through the T cells, and therefore they will help each other to diminish the production of the cells. We call the cancer cells. And where do you produce the white blood cell? Of course, from your bone marrow. We call them the stem cell. What are the stem cells? White blood cell, red blood cell, and platelets. Produced from your bone marrow. Relation of nutrition to immunity and healing. Okay, this is something very important in principle. Balanced nutrition maintains immune system, as we were saying all along. Malnutrition reduces capacity of the immune system via atrophy of organs and tissues involved in immunity. What does that statement mean? If you are malnourished, your capacity for immune defense is also very low. That's the meaning of that statement. Because it leads to the atrophy of organs and tissues involved in immunity. What are the organs and tissues involved in immunity? From your immune system? The spleen, the liver, the blood. They're helping each other. The thymus gland, they are the tissues. The lymphoid system, the lymphatic system, the lymphoid tissues, they are the different organ that is involved in body defense. We reinforce the immune system. Nutrition is vital combating sustained attacks of disease like cancer. Therefore, the bottom line here is you have to have a very good immune defense and a very good healthy nutritional status so that your immune system is maintained. Therefore, cancer will be far away if you have that kind of status. Meaning that there's really a relation between the level of your immune capacity and malnutrition. Healing, strong tissue is fundamental to immune system. So if you have lack of protein in your tissue is not strong, then your immune system is what? As we said, even your antibodies are protein in themselves. They are made up of protein. Therefore, healing could be far behind if you have problem with immune system. Tissue building and healing requires optimal nutrition. Vigorous medical nutrition therapy is speech recovery after surgery for cancer, just in case you have surgery. So meaning they are very related. Nutrition is very central to the treatment and at the same time to the prevention of cancer. Three major forms of therapy used to treat cancer: surgery, radiation, and chemo. Okay. Oh, okay. As we said in nutrition this morning in the first chapter, what is the role of protein? For healing, for tissue growth, for fluid volume restoration, for prevention of edema. Now, what do we have to add up here in this particular chapter as to the role of protein? Immunocompetence, right? Did you see that? Meaning, the competence of your immune system is also dependent on protein. That's why take note, Nutrient responsible for tissue integrity and immunocompetence is protein. Therefore, if you have cancer or immune problem, protein is also something very important to be maintained. Because your immunocompetence, your ability of your immune system to launch an attack is dependent on the adequacy of your protein. Okay. So what I'm trying to say is, because of medical nutrition, it will lead to immunocompetence. That's the word, immunocompetence. All surgery requires nutrition support for healing. General condition of cancer patient often is weakened by disease process. So now, during radiation therapy, what could be the problem on nutrition? So, radiation normally kills what? Both normal and abnormal cell, right? So therefore, if you kill a cell which is normal, then what would happen? You're doing what? Tissue catabolism. You destroy tissues in cells. So, what would be the major systemic effect of cancer on the patient? Okay. As we said before, when you have cancer, how do you compare the development and the proliferation of cell in cancer than the normal cell, which has faster, growth? The cancer, right? So if you have more cancer cells proliferating and developing, those cancer cells needs what? Oxygen, nutrients, blood. Therefore, it will have to compete with the nutrients, oxygen, and blood due to the normal cell. If that is the case, what could be the effect of that? Because of cancer, you have so much cancer cell developing, and you're trying to destroy the other normal cell. So therefore, it results in what you call a major systemic effect of cancer, negative nitrogen balance. So if you will be asked, what is the systemic effect of cancer on the body? Negative nitrogen balance. Why? Because of what you call hypermetabolic state. When you have cancer, the metabolism of the body increases because of the increased proliferation. Cancer cells divide so fast, more than the normal cell, and therefore they need metabolic activity. That's why we call it hypermetabolic activity of the cancer cells that produce a negative nitrogen balance. Do you follow that explanation? Can you understand that? Why you develop negative nitrogen balance? Because of the constant proliferation that account for the destruction of other cells. Also, in radiation therapy, since you are destroying other cells, you also that also lead to negative nitrogen balance. But not only that, the problem is during radiation therapy, it will suppress your bone marrow activity, right? If you suppress your bone marrow activity, it will not produce what? It will produce less red blood cell, white blood cell, and platelet. And therefore, one of the effects of radiation therapy is what? Anemia. Because of reduced, we call it bone marrow suppression. You have reduced RBC production, you have reduced white blood cell production, therefore you are at high risk of developing infection, and you also are at high risk of developing bleeding because of lack of platelet. Those are the three things that could happen to you as a result of continuous radiation therapy. If you suppress your bone marrow, you also suppress your what? Immune system. Because it's WBC that produces the capacity to protect the body against invasion. So that is the double jeopardy that could happen to the body when you have you're trying to treat a cancer, but on the process of treating, you are causing the immune system to be down. Therefore, we have to be very careful protecting the patient against infection or bleeding, and of course, nutrition, as we say, has a very central play or role to play in that regard. If you are bone marrow suppressed. Also, some of the other thing is the sense of taste may be affected, and therefore you suffer from anorexia. And some of the effects of radiation on the GI lining, it causes what? Irritation and over-secretion of acid, and therefore that could cause nausea and vomiting also, and anorexia, and therefore that could lead to further malnutrition. That's why radiation, which is a treatment for cancer, could lead to problems of nutritional status. Okay, and of course chemotherapy, just like radiation, could cause bone marrow suppression, GI disturbances, and of course hair loss, just like. But you see, for example, patients with cancer are what? You could combine both chemo and radiation, right? All the more you suppress the bone marrow, and that could be a lot of problem as to nutrition, as far as nutrition is concerned. So the drugs that normally is used for chemotherapy lead to anemia, can cause anemia because of it suppresses the red bone marrow to produce red blood cell. Anti-neoplastic drugs have drug-nutrient interaction. Some patients use herbs to prevent or treat cancer can have food-drug interaction too, meaning the medication that we take for cancer could also have an impact on our ability probably to take in food, because others could cause nausea and vomiting, it could suppress our appetite and all that, and therefore it leads to further malnutrition. General systemic effect of cancer, what's that? We have already mentioned. Negative nitrogen balance is here. In general, these are the systemic effect: anorexia, increased metabolism, we call it hypermetabolic state, and negative nitrogen balance are the most important systemic effect of cancer. A specific effect related to cancer depending on location and tumor. Of course, like tumor in the brain, one of the effects is what? Intractable pain. Pain that you can, even with medication, at times you cannot control the pain, because it is pressing so much on the tissue that causes pressure on the nerve ending that accounts for the pain. So, if you are treating a patient who has cancer, what would be the primary goal of medical nutrition for cancer patient? Basically, the main goal is to prevent malnutrition. You can take note of that. The primary goal in nutrition for cancer, for patients with cancer, is prevent malnutrition. Have you heard about cachexia? What is cachexia? Cachexia is a state of profound weight loss, reduced food intake, and systemic inflammation. So the patient becomes very thin. Have you seen a patient like that with cancer? He becomes very thin. His capacity for intake of food is reduced, and he has systemic inflammation in the body. cahexic, cachexia. And therefore, we would like as our goal is to prevent malnutrition for this kind of client. Medical nutrition to meet increased metabolic demands of disease process. Here are some of the following. Medication to increase appetite, like Megase, for example. That is stimulate appetite stimulator, normally given before breakfast. Of course, medication that reduces vomiting or nausea, prevent protein degradation, or increase caloric intake. So, those are some of the medications that can be used to enhance nutrition in a client. Relief of symptoms could be stress management, pain management, relaxation techniques, psychological support, and physical activity. Meaning these are what you call biobehavioral interventions. They are not medications, but they are interventions that would lead to diminishing symptoms and promoting comfort of a patient with cancer. And they are not even nutritional interventions. So if you are a cancer patient, we normally evaluate the need because of the rapid changing condition of the patient, the need for nutritional help. Okay. So let me see. To counteract what you call hypermetabolic state in a cancer patient, what do you have to increase? As we said, what is hypermetabolic state? What do you consume so much when your metabolism is fast or high? What kind of macronutrient does the body immediately uses? What energy? Carbohydrates. Therefore, what could be your intervention to counteract hypermetabolic state? Increase calorie for energy. Because if your metabolism is fast and you're using a lot of energy from carbohydrates, therefore you have to increase calorie, definitely from carbohydrates. And the reason for that is we would like to spare the protein of the patient. Preserve the protein for its activity that is proper to itself. So take note of counteracting hypermetabolic state by giving or increasing calorie intake. Of course, for obvious reason, for energy. Medical nutrition. Okay, let me go to nutrition management. Well, this can also be resorted to when there is a problem with oral intake. You can also have enteral feeding. The patient cannot really, he is constantly vomiting or nauseated, therefore we can have enteral feeding for that reason. Another problem that patient who has cancer is decreased salivary secretions. And if the salivary secretion is absent, what could be the intervention so that nutrition can be given to the patient? What kind of food, in terms of probably the texture of the food, is most appropriate for patient whose salivary secretion is reduced or absent. Meaning, if you swallow, you have difficulty of swallowing because you're always dry in your mouth and in your throat. Okay. Serve semi-liquid food for that kind of. If the patient is having oral for feeding, can take it orally, and he has that kind of salivary problem, then he needs to you need to serve the food in semi-liquid form, either by normally puree, semi-liquid. For loss of appetite, well, that is also one problem for patient with cancer. He has he loses appetite. Maybe not only because of the cancer cell, but also because of the medication that he is taking, the chemotherapy or the radiation. Altogether, these factors combined causes loss of appetite. Can lead to cachexia, which I already described to you, when you have severe weight loss and you're not eating so much and there is a general inflammatory condition within the body. We call that cachexia or cachexic. So at this point, when patient has no appetite, because normally we eat because we have appetite to eat. What if you don't have the appetite? Would you just leave the patient not eating because he has no appetite? No. We have to give him nutritional food. So one of the measures that can be done for loss of appetite is you have to investigate what is the cause. If the cause of loss of appetite is because he is constantly suffering from pain, when you are in pain, normally you don't want to eat, right? You can eat. And therefore, assess patient for discomfort and provide pain relief measures. That could be your intervention for loss of appetite. If the patient is having some discomfort or pain, then you have to give the patient pain medication before eating. Otherwise, he will not be able to eat. Can you eat with your teeth aching? Of course, your attention is on the pain. So any pain at all that causes lack of appetite. But what I'm trying to say is, we have to investigate the source of the anorexia and try to treat them. If it is discomfort or pain, then give pills for that. If it is nausea, resolve nausea. So that's why we have here, as we said, pain and discomfort, then you have to give medication for that. Enteral tube feeding. So we were saying this before, that if you cannot eat, then enteral feeding could be indicated. Indication include inadequate oral intake, oral route contraindicated, or patient is comatose. Some patients can be fed overnight, allowing them to be free from tube during the day. So, depending really on the condition of the patient. And parenteral feeding can be done normally on a long-term basis for a long period of time, so you can have TPN, so that you will not have any problem receiving all the nutrients necessary through the total parenteral nutrition. Now, one problem with patients with cancer, especially when there is severe bone marrow suppression, is what? What happened to your, is it granulocytes? What are the granulocytes? Basophils, neutrophils, and eosinophils. What happened to your neutrophils?
It's low.
It's very low. So what do you call that condition when your neutrophils are very low? Yes, neutropenia. So what could be your intervention for patients who are neutropenic? If you are neutropenic, what are you at high risk for? What kind of infection? Neutrophils is for, what is the specialty of neutrophils? Bacteria, basophils, allergic reaction, and inflammation. Eosinophils, parasites. So therefore, any bacteria around you should be prevented coming into the patient. And that's why we put the patient in what you call neutropenic precaution. What is neutropenic precaution? What would you not allow inside the patient's room? No fresh flowers, no fresh plants because they carry bacteria. Okay? No raw food to eat. Meaning every food should be properly cooked because raw food normally has a lot of bacteria than cooked food. So therefore, one of the interventions for neutropenia is cook the food as soon as possible after thawing. What is thawing? Thawing. Thawing. Thawing the food. Meaning you don't let the raw food, if it is a meat, to stay fresh for a long period of time. Cook it right away after you have prepared it. Because the more you expose that food, the more bacteria normally multiplies in there. So that would be a particular intervention for neutropenia. So did you take note of that? Yes, sir. There will be few questions from this, maybe 6 or 7 questions only from this chapter basically. Oh, no, 10 or 11, not 5 or 6. Yeah. So let me go directly into cancer prevention. Anyway, I don't need to discuss this to you because you will think it's in your medical surgical nursing. Maybe as far as nutritional consideration is concerned, what we have to consider here. Consume a healthy diet, limit alcohol consumption, do not rely on supplements, adopt a physically active exercise, be as lean as possible within normal range. So those are some of the preventive, what you call that, TLC. Therapeutic life changes that the person will adopt so that he will be able to prevent cancer. According to the American Cancer Society, it is what we need to do and adopt as a new way of life so that we prevent cancer in ourselves. But let's continue from here. U.S. Food and Drug Administration claims approved for labels. So, to prevent further cancer, because we know we associate some kind of nutrient to cancer development. Low total fat, meaning saturated fat, reduce the risk of some cancers, including colon cancer, for example. Fiber-containing grain products, fruits and vegetables, because of their antioxidant nature. The presence of antioxidant in fruits and vegetables normally, because they are the one that destroy the free radical in your body. What are free radicals? They are independent element in your body. When, like for example, sodium chloride, when they dissociate with each other, they become free radical. The sodium alone is a free radical inside the body. Okay. And then fruits and vegetables may reduce risk of some types of cancer. Ongoing cancer research, foods that may increase or risk for breast cancer, gastric cancer, colorectal cancer. As we said, there is no direct link as to food or substance that really causes cancer. Only associations. Nutritional support for HIV. So after cancer, we have HIV. Is it the last subject?
Yeah.
Oh, I think so. HIV. So, a little background about HIV. The main problem with HIV is once the virus is in your body, it attacks which kind of T cells in your body?
B cells.
Which T lymphocytes is that? Is the CD4. What is the CD4 responsible for? What does it do? It is the one that stimulates what? Antibody production. If you don't have a T lymphocyte that would stimulate antibody production, how else can you produce antibody? Therefore, if you don't have antibody, how can you protect yourself from the invasion of this retrovirus, as we call it? We call the HIV virus or retrovirus. So therefore, depending on how far the virus has invaded your system and destroyed your CD4 cell. What is the normal CD4 cell in the body? 900 to 1500. But if your level is something like 200 plus to 499, meaning that's already the second stage of your AIDS. When your CD4 count is something like below 200, that is where opportunistic infection comes in. And when you have those infections, that's the time when you die. Meaning the patient does not die from the HIV virus, but from the infection, because the body can no longer fight the infection because his CD4 cell is very low, 200 and below. That's very critical. So once you have the HIV with you, you could prolong your life, but you will die from opportunistic infection in the future. Depending on how your body is responding to the medications, the antiretroviral medications, how you have changed your lifestyle, you have a clean living, nutrition, then you probably could prolong your life for so many years, asymptomatic, but just the same, in the end, that virus will still cause the diminution of your CD4 cell that could lead to opportunistic infection. And a lot of people with HIV normally die from what? Pneumonia, because it attacks the lungs. The opportunistic infection is attacking the lung, that causes what? Thickening of the secretion, that you can no longer cough it out and you cannot defend against the infection. In all other opportunistic infection, including fungal infection, so you really die from infection because you don't know how to defend your body from the very low CD4 count. That is basically the explanation why there should be adequate nutrition for people with HIV. So, nutritional support throughout HIV progression has its role in, so meaning, why do you have a nutritional support throughout the HIV progression? Because on the first time when the HIV enters your body, normally you are just detected as HIV positive. Maybe after some weeks or 3 months and you become HIV positive, it will take time until you develop the later stage. That is why it's very crucial that we try to maintain the CD4 count within that 900 to 1500 level through antiretroviral medication. The earlier you are detected, the better you can be sustained and nutritionally enhanced Therefore, your immune system is better with proper nutrition. So the nutritional support throughout HIV progression has its role in what? Why do you give nutritional support for HIV? I think that's the question. Because we would like to control involuntary weight loss and tissue wasting. Have you seen a patient with HIV towards the end stage? It becomes what? Bone and skin. Very thin. Kahexic, as we already described. Kahexia. He loses a lot of weight and there is so much tissue wasting. All your muscles have been eaten already and therefore you become very thin. Sunken eyeball, in cheeks, you're really very bony at that time. And this is what we would like to prevent from happening, to control involuntary weight loss and tissue wasting. That's why we have to have that nutritional support throughout the HIV progression. Depending on what level, then there is a particular need for nutritional support. So what is the fundamental effect of HIV? Another question. Fundamental HIV major effect on the body is what? Weight loss. So one of the indicators that HIV is really progressing is you're losing weight. Maybe without you knowing it. And at the same time, by that time, you become prone to respiratory infection. You easily develop infection when you have the progression of the HIV. Okay. Where did HIV came from? Where did it came from? Did it come from America? Historically, they said that HIV came from monkey, yes. And that monkey were eaten by the black African American from the sub-Saharan desert. And therefore, the HIV virus was transferred to the humans. And that's why they said that 90% of all children in the world afflicted with HIV are coming from from Africa. Because 60% of all women in the world afflicted with HIV are coming from Africa also. So through the fetal maternal circulation, the fetus receive the virus. So when they are born, they are already having HIV. And this is what you call already today a pandemic. It is pandemic because it's affecting a big major chunk of the population all over the world. How many millions? I think more than 30-something million are HIV positive. What about those who are yet to be diagnosed or undetected? Therefore, it has a very large proportion that makes it a pandemic event. Or, statistically, you call it pandemic. It's not only an epidemic in a local area, but it's a worldwide kind of thing. But more so in Africa and of course in the United States, where there is a very loose morale and sexual permissiveness, there is a high incidence of this. That's why when there is for advanced countries like Europe and the United States, where sexual permissiveness is a very ordinary thing of the day, there is a high incidence of this particular HIV. And to think that there is no single vaccine that could prevent it because of the constant mutation of the strain of the virus. It can hide itself anytime. Today, this strain is detected in affected people, but tomorrow it becomes another strain And therefore, how can you trace that strain and find a single vaccine for the virus? So we cannot prevent the virus to be spreading because there's no vaccine. That unlike measles, influenza, the, the diphtheria, and all of these communicable diseases, we can control them because there are specific vaccines that could make the person immunized. But you cannot immunize yourself against HIV because the DNA of the virus mutates every single day into different strains. So how can you find a particular effective vaccine for that? No, no way. We are just trying to use the medication. What's that for? To diminish the appearance of symptoms and prolong and increase the immune system of the patient, but eventually he will die of opportunistic infection at the same way. So there's no point of coming back again to normalcy. But you know, there are a lot of HIV positive who are advocates already against HIV, right? They're talking to people, they're living a healthy lifestyle, they are happy, maybe for the rest 10 years of their lives. Because after all, they will die. So it's difficult to have this kind of things. So, what would be your nutritional plan for HIV/AIDS? Meaning, when we're going to plan a nutrition program for this kind of people, what is the characteristic? It should be individualized, and it should be adjusted throughout the course of the disease, throughout the course of the disease, meaning throughout the progression. Meaning we adjust the nutrition intervention for this client depending on what is needed on the initial, of course on the end stage when the patient is really very sick, then there's another way to treat it. So individualized and adjusted throughout the course of the disease. And if you're going to make a counseling, what guidelines are you going to follow for counseling HIV client? It is said that you have to promote optimum nutrition while making fewer food changes. That is a basic guideline for counseling HIV. We just would like to promote optimum nutrition and while making fewer food changes. Because normally if we keep on changing the food, it will probably cause other complications and irritations. Therefore, let him be on the food that would really fit into his body system. If there's gonna be change, it should be few in terms of the food. Avoid so much changing food. But you have to, your goal is optimum nutrition all the time. Did you take note of that? Yes. Okay. I have nothing more to say. Still the chapter is long, but it just like you say. Okay. So as I said, the patient dies from opportunistic infection, and therefore part of our care is recognizing signs of infection and treating accordingly. So what is the central management? Of course, diet, the medication, and what the other one? Other biobehavioral interventions. Vaccine would train. Do we have vaccine here? Vaccine would train body's immune system to identify and destroy HIV. Vaccine undergoing trials in Thailand considered somewhat effective. Said CDC and NIH working with other worldwide agencies to coordinate development of effective vaccine. Because until this time, we don't have really one single vaccine that can be to prevent HIV or you can be immune from HIV infection. sign up today? With nutrition. That ends our nutrition. So, if you would notice,